All right. Good morning, everybody. Welcome to another CMR conference here at VCU. If you don't know me, my name is Mohammed Makkiya. I'm a cardiac imager, general cardiologist, and I run the Hypertrophic Cardiomyopathy Clinic here at VCU. And today, little bit on time constraint. I have to go to a remote clinic, and I'm going to talk about valvular heart disease and evaluation utilizing CMR for that. I have no disclosure for this talk. And then today we're going to talk about how do we evaluate heart diseases by CMR, when to use the CMR for evaluation, quantification of heart disease by CMR, and additional information that the CMR provides when we do that. So how do we evaluate heart disease by cardiac MRI? We use a couple of features. We use cine imaging like SSFP imaging or gradient echo imaging. We use phase contrast velocity mapping. So in cine imaging, the SSFP imaging, which is the workhorse of cine imaging, it has a low sensitivity, it has some limitations, and we should know about. There is low sensitivity for regurgitant jet as echo time is too short. Issues with inhomogeneity artifacts, with very high velocity blood flows, can miss small jet masses due to the slice thickness. Usually MRI slice thickness is about 6 to 8 millimeters, while valve can be as small as 2 millimeter thin. And to avoid this, we try to take multiple slices perpendicular to the valve. We can also use gradient echo in evaluating valvular heart disease, which has higher sensitivity for regurgitant jets, best sensitivity with longer echo times, more than 6 millimeters, allow more for dephasing of MRI spins and which destroy signals. Keep in mind that modern gradient echo protocol has a small echo time around 3 milliseconds. So consider increasing that to increase the sensitivity. Phase contrast velocity mapping, which is the main tool that we use one of the main tool or gold standards that we use in evaluating valve disease. And it's an important tool that helps us assess the flow direction. We can also quantify the flow. We can measure the flow velocity, and by measuring the flow velocity, we can evaluate gradients. So let's talk briefly about physiology. This is a lecture by itself, but I'm going to try to be brief and simplify this. So phase contrast velocity mapping is dependent on proton precess phase. The phase of precession is dependent on the degree and the strength of the magnetic field. And where the proton in their spinning phase is dependent where they are located in the magnetic field. As we see here, when a magnetic gradient is applied to an artery, for example, and as the proton move through the artery, the precess phases changes, like we see here. As we move down the artery. And as we see here, when a magnetic gradient is up, and now if we switch and apply an equal and opposite gradient, the initial phase of recession is going to reverse. Proton who move faster than the slow or stationary proton, which mean that they have higher degree of precession phase, in turn will have a higher phase shift, which correspond to velocity. And this is like a brief about the physiology behind the phase mapping or phase contrast velocity encoding. So how do we do that? We have two ways of doing that. We have in-plane or through plane coding. The in-plane coding, which I'm showing here, I don't know if this is plays, doesn't play, where the velocity is encoded within the plane. It is helpful to assess the direction of the jet, especially if you have an eccentric or multiple jet. It also can tell us where the jet starts and its width. As we see here, an example of a patient I have with a hypertrophic cardiomyopathy and subaortic membrane. We can see on the right hand here the flow jet, and the higher the velocity, the higher the velocity, the darker the blood flow jet is, which is coming from the area of obstruction. You can also pinpoint the area of obstruction like a PW and echo. And you can also see there the point of which the step up in velocity occurs. And with that, you can determine where exactly the higher the velocity is, which about here in the LVOT in this case. In most of our study, we do a through plane velocity encoding, which we encode our velocity through the plane of the slice. This is a technique we use to do flow quantification in order to measure velocities and gradients. However, we have to keep in mind that if we need to get a good through plane imaging, we have to be, regardless of the jet direction, as much as possible perpendicular to the jet direction. So we have to set up unusual double oblique images to get a true through plane imaging. That's very important to get accurate measurements and accurate jets. Here we see the velocity encoding. I showed two pictures. It's usually plays good. And displayed in two images, magnitude and a phase image. We see the magnitude image on the left. The flow coming toward us is usually white in color. And in the phase image on the right, the flow toward us usually, or the regurgitant flow is usually dark in color. And this is how we generate our through plane velocity encoding images, by putting our cuts just slightly above the aortic valve, close to the aortic root, using two oblique planes, and try to be as much as perpendicular to the jet direction so we can get our phase imaging. Then you can load these imaging into any software that you utilize or your institution utilize. Then you can do your quantification. What we need to do is to find a good image and circle your region of interest. In this case, we're looking at the level of the aortic root, and then you can propagate this to all slices throughout the cardiac cycle. Make sure you include all the flows within the aorta, and to exclude all other outside the flows like the RVOT or SVC. Should not have that in your sampling, as this may contaminate your results. And with that, we can get our summary. We see here on the right-hand slide the picture. In the picture, both measurements in measurement form or in a graphic form, that includes our peak velocities, forward volume, which is the area above the curve, or reverse volume, like here you have some regurgitation, which is area under the curve. That happens later in the cardiac cycle. Like this guy has a combination of some aortic stenosis and aortic regurgitation. So important consideration when you're doing a phase contrast imaging: make sure your spatial resolution is appropriate. Like if the vessel gets smaller, you have to have a high spatial resolution to prevent artifacts from partial volume averaging in our flow measurements. You should have some consideration about the temporal resolution. Usually MRI temporal resolution is not like CW in our echo. It's about 20 to 50 milliseconds versus CW is about 2 milliseconds. And with that, you have to keep in mind that you may miss peak velocities as your temporal resolution is not fast enough. This modality is dependent on the flow being laminar and have homogeneous field. phase shift errors happen or can happen when you have eddy currents resulting in inhomogeneous fields and turbulent flow with high acceleration. This typically occurs at high velocities, like when we evaluate for aortic stenosis, and you have velocities more than 4 meter per second or 3.5. This effect although this affect the accuracy of our velocity measurements, however, once we reach that in aortic stenosis, we can that doesn't matter much, as we can establish the velocity is severely elevated. Aliasing. We get aliasing, which is in turn leads to erroneous or velocities measurement. This happens when the valve velocity is higher than the set velocity at the scanner. We call it the VENC. Typically, if the scanner high velocity VENC is usually set at 2 meters per second, and the valve velocity, let's say, for example, is higher than that, like in this case that I'm showing is about 2.5 meters per second, and the VENC was set at 2 meters per second. So aliasing will look like this dark flow coming toward you in a sea of white. The solution for that, or how do you troubleshoot that, is retake your imaging after you increase your VENC velocity, as we did here in the right side picture. I make a habit on, also like some people, or me included, I make a habit of looking at patient echo before doing an MRI if it's available, especially if I'm looking for aortic stenosis case, and I kind of see what's the velocity is, and I can tell the techs to set the VENC starting at that velocity to get over aliasing. There are some vendors which automatically takes multiple images or provide multiple imaging at different VENCs to solve for that, but that's on the expense of some scanner time. So when do we do MRI? It's the second line to echocardiogram. We do echo because it costs less and the information can be readily available and quick, and we can do it at bedside, doesn't require a lot of preparation. However, echo is like looking at, keep telling my patients, we are looking at a movie in 2D versus MRI. We are looking at movie now in Ultra HD, and we can tell someone why this cardiomyopathy is happening. Echo, most of the time we cannot. CMR has a distinct advantage over echo for its evaluation of right-sided valves, in particular the pulmonic valve, which is not visualized well on transthoracic echo, and even on transesophageal echo. We can clearly visualize it in both in-phase and right ventricular outflow tract views on CMR. It is also advantageous to use CMR for right-sided valve dilation in congenital disease. It's the workhorse for that, where there is distortion of anatomy or other associated cardiac defect can be missed on echo. Furthermore, RV volumetric assessment using either SSFP can provide more accurate assessment, and it's a gold standard compared to 2D or 3D echo. Add to that, quantification of valvular regurgitation or stenosis can be obtained with the phase contrast imaging, as we discussed. And we all have these echoes for like we have an obese patient or patients with COPD or breast implants that really affect the quality of our study, and we cannot really fully evaluate the valves. That is the time MRI can be used, which is non-invasive, rather than doing a transesophageal echo to evaluate valve anatomy, assess the severity of valve disease, and quantify that. So we're going to go into valvular disease and the role of an MRI in each one of them. We start with aortic stenosis. So how do we evaluate aortic stenosis in MRI? We use several techniques. We use splenimetry, and we use phase contrast velocity encoding. We start with splenimetry. In order to get an accurate splenimetry, again, we have to really allow align our images as accurate as possible to get a good short axis view for the valve, which we can later utilize and do our area by planimetry. In order to do this, you should use two planes to construct your short axis view, as we I'm showing here. And as you see, the aortic jet stenosis has a white core in it and dark rims from the turbulent flow, and it can be angulated, like in this case here, not as parallel to the aortic root as we expect it to be. So try to obtain an image with another plane more parallel to the jet by placing my image line parallel to the jet core, like we see here. This line is, like we see here, and get more aligned image to the valve. And I use that to place my image slice just right to the tips of the valve, where it's mostly, you need to be at the tip of the valve, so you avoid overestimating your valve area. And then that will generate this short axis view that we later realize and measure your area by planimetry. And also, I would advise obtaining a couple of cine slices above and below the tip and use that for measurements. Now, here is a meta-analysis of several studies where they did comparison of cardiac MRI to transesophageal echo and assessment preliminary for aortic valve area. We see here in the forest plot of aortic valve area measurements, mean and standard deviation for CMR and TAE demonstrate no significant differences between the two modalities. So phase contrast, we can evaluate aortic valve stenosis by velocity encoding phase contrast imaging by measuring peak velocity and get the peak gradient by Bernoulli equation. And since we know that the scan time, we can assess mean gradient as well. The MRI has advantage over echo Doppler for angulated jet, like I showed earlier, where Doppler underperform. However, in MRI, we can easily realign and avoid geometric assumption and realign our images parallel to the jet if it's angulated. We have to keep in mind that, as I mentioned earlier, I'm showing the same picture of the same patient, that CMR velocity measurements can tend to underestimate the actual velocities from the turbulent flow. Also, CMR accuracy can be limited at a higher velocity, specifically when it's more than 3.5 to 4 meters per second. But you can establish diagnosis by then that is most likely severe. Added advantage of MRI. MRI has more advantage of an echo as better visualization of the valve due to the echo spatial resolution and artifacts from calcium and shadowing artifacts from calcium and ribs and all of that. It doesn't matter what is the size or angle of your aortic root or the size of shape of your patient. Also, you can assess, like in this case, some other associated condition with the valvular disease, like this bicuspid valve patients. You can assess for aortopathies and do an MRA and assess the sizing of the aorta, and that can help you in can help in guiding intervention. And of course, MRI can assess the impact of echo on the LV, which can also help us in making the clinical decision, as MRI is the gold standard in assessing LV function and dimension. Another added advantage for MRI that it can provide some prognostic value with severe AS. This is a very growing field. In the recent CMR, they showed some also cases or research that is ongoing in this field. This is a Kaplan-Meier plot showing all case mortality on the left and cardiovascular on the right mortality in about 700 patients treated with surgical aortic valve replacement and transcatheter aortic valve replacement, according to the presence of absence of LGE perioperatively. We can see that LGE, despite intervention, can lead to poorer outcome and mortalities. And this is, as I said, an ongoing field. Some studies are trying to assess that asymptomatic severe AS who don't fall in the guidelines to intervention, just monitoring, and they are assessing for intervention based on LGE. And there are some promising results for that. Like this one, Kaplan-Meier survival plot showing all-cause mortality in patients with severe LGE, whether LGE is due to a combination of infarct or non-infarct. And we see in the LGE in the non-infarct pattern is associated with worse outcome, but of course, the combo infarct with the non-infarct and infarct is the highest versus patients who have aortic stenosis and no LGE. So for the purpose of time, I'm going to skip this case. So aortic regurgitation. So this is an HCM, and briefly, this is an HCM and aortic stenosis case of a patient that we have here, where echo, you cannot really tell if you have the gradients because of the LVOT obstruction or aortic stenosis, and MRI can be a very helpful tool for that. And we assess both in that case. Aortic regurgitation. So how do we evaluate aortic regurgitation in MRI? We can do that visually, where we can see the dephasing jet and can identify the mechanism of aortic regurgitation by evaluating the valve and associated structures like the thoracic aorta dimensions. And planimetry by measuring the aortic regurgitation orifice area from the CNA-CMR acquisition. And a study that showed that an aortic regurgitant orifice area of more than 0.5 centimeters square was found to have a sensitivity and specificity of about 83 to 97% respectively in detecting severe AR. And then the gold standard is the phase contrast, which is the major player here and the crux of MRI assessment for regurgitation, for aortic regurgitation. As I mentioned before, we really try to build our imaging using two oblique planes, and where we can place our image slice slightly above the aortic valve. We can do our flow measurements for AR and generate our phase contrast and use that to utilize our flow measurements. And then you can get from the software your regurgitant volume. And by knowing that, and by knowing your forward volume, you can calculate the regurgitant fraction, which is 22% in this case. Sometimes direct quantification method can be compromised in the presence of arrhythmias, for example, atrial fibrillation. So in these instances, multiple indirect methods can be used to determine the AR severity. For example, in the absence of significant pulmonic regurgitation, aortic regurgitant volume can be derived by subtracting the pulmonic forward flow from the aortic forward flow. Another indirect method we can utilize if our hands are tied, by comparing the LV and RV stroke volumes obtained by SSFP image CNA planimetry. However, this is not reliable if there is significant coexistent mitral or tricuspid regurgitant lesions. Here is a study done at University of Oxford. They recruited about 250 patients who have asymptomatic and moderate to severe aortic regurgitation with no indication for surgery. They quantified aortic regurgitation using MRI and wanted to predict to predict which one of them will have poor outcome without intervention, even if they are symptom-free. And they found out that patients who have regurgitant fraction more than 33% per se are associated with poorer outcome and worse symptoms without intervention. Of course, this won't tell you if the surgical intervention before the symptom will affect the overall outcome. We need to study this more in the future. Several studies have showed that reverse holodiastolic flow in the descending aorta on flow studies is associated with severe aortic regurgitation with a good sensitivity and specificity. In this study, holodiastolic flow reverse, as we can see here in the flow chart on the top right image, can have also a prognostic information, and it's associated with poorer outcome, as we see in the Kaplan-Meier curve below, indicating severe aortic regurgitation. Mitral regurgitation. Before I talk about mitral regurgitation, I need to make note that MRI in mitral stenosis is limited, and the gold standard is still echo or transesophageal echo, as we don't see the valve as well as we see it in echocardiogram. And also echo can help us in guide treatment or monitoring intervention like balloon valvulotomy. But MRI can perform very well in mitral regurgitation. I would say that echo, especially 3D echo, is still the gold standard in MR evaluation, but I may be mistaken and I can show you, I'm going to show you some proof after that. MRI is a good addition in case our echo evaluation is limited or there are some measurement discrepancies. With MRI, we can see the potential mechanism. We can evaluate the reason for mitral regurgitation. We can see the leaflets, LV and subvalvular apparatus morphology like papillary muscle anatomy, chordae function, and all of that. We can also quantify regurgitant volume indirectly and evaluate regurgitant fraction. And finally is the gold standard for, as I said, for LV dimension measurements and function. Now, here we have 3 cases of MRI. Let me play it for you. 3 cases of mitral regurgitation caused by different mechanisms. MRI can be very helpful with that. As we can see in the first case on the left, there is a posterior leaflet prolapse with the resultant anterior regurgitant jet. In the middle, there is an HCM patient where you have SAM and a posteriorly directed mitral regurgitation, and that's the reason for that. And in the third case, we have dilated cardiomyopathy with significant MR, and which is a normal leaflet morphology. This is most likely for functional MR from the dilatation. So how do we quantify mitral regurgitation? We usually use the difference between the LV stroke volume measured by planimetry on the short axis in CNA images, mostly SSFP images, and aortic valve stroke volume obtained by phase contrast imaging. Or we can do the difference between LV and RV stroke volume measurement by CNA imaging, or the difference between the mitral inflow stroke volume and the aortic stroke volume by phase contrast imaging. Keep in mind that phase contrast for direct assessment of flow on the mitral and tricuspid valve has some can be difficult because of significant motion of the annulus during systole. So the direct method or the most method that we use is we obtain our stroke volume like we hear in any software you use on the left, and get your LV stroke volume, and we use phase contrast imaging of the aortic valve to calculate the aortic valve forward flow, and we subtract these and we get our regurgitant volume. Or regurgitant mitral valve volume. You can also calculate the regurgitant fraction from that. So in this interesting prospective multicentral study, about 150 patients showed that there is substantial discordance between MRI and echo when grading the severity of mitral regurgitation. As we see here in the pie chart, as we see here in these two pie charts, and it seems that echo tends to overestimate the severity of mitral regurgitation, depends how you look at it, or MRI underestimate that. So like if you are an echo person, you say that echo is more accurate than the MRI, and MRI can underestimate the valve regurgitation. However, in the same study, they report these interesting results that after undergoing surgery, it seems that MRI is better than echo for predicting the ventricular response to surgery, suggesting that it is more accurate than transthoracic echo in assessing the severity of mitral regurgitation. Another study from Oxford showing that CMR can provide prognostic information in patients with moderate to severe asymptomatic mitral regurgitation. Similarly to aortic regurgitation, MRI can help to predict those who will eventually do worse in regard to symptoms and outcomes based on the degree of mitral regurgitation, as we see here in the KP curves, top left, while on echo, quantification did not predict any events to distinct the two groups, as we see here in the KP curves on the right. They also showed in the study that echo tends to overestimate the degree of mitral regurgitation. Pulmonic stenosis, I would say again, MRI is the gold standard for evaluation of right-sided valves, especially pulmonic valve disease. And that is we evaluate that, especially in the adult congenital heart disease, where patients who have tetralogy of Fallot repaired, and you want to evaluate them for pulmonic stenosis or pulmonic regurgitation. Also, we can see we can get excellent images with CMR compared to echo to evaluate the RVOT, and we can get the main pulmonary artery flow and get good cine images of the pulmonic valve. We can plan our short axis flow images in the same like we did in AS. Let me play these. By placing our image slice at the valve tips, that will generate like here, that will generate nice short axis view that we can utilize to do our flow quantification and assess the degree of regurgitation and stenosis. And as we did with IR, we can do the same with pulmonary insufficiency by putting our image line just above the valve leaflet to get away from the turbulent jets after obtaining a main pulmonary artery flow or phase images. And we can also use that in our software and calculate our regurgitant fraction, regurgitant volume, and regurgitant fraction. So in summary, the role of MRI in pulmonary valve disease, visual assessment of the valve, assessment of RVOT. It is considered the gold standard for RVOT anatomy and assessment. As I said, echo tend not to do well in evaluating RVOT and pulmonic valve, as they are located just below the sternum, and you can have a lot of artifact, and they are poorly visualized, even with transthoracic, transesophageal echo. Quantification of valve stenosis and velocity and valve regurgitation, and the most accurate in RV volume and function measurement. So role of MRI in tricuspid regurgitation. Tricuspid regurgitation by MRI is secondary to echo and is less established compared to other regurgitant valvular regions. Right ventricular, how do we quantify that? Right ventricular volume can be calculated directly from our SSFP cine images, and we can subtract that from the pulmonic forward flow. So we can derive a regurgitant volume and regurgitant fraction, or we can do that indirectly by measuring the aortic forward flow, forward volume, and subtract that from the RV stroke volume in the absence of aortic regurgitation. Or LV stroke volume can be always also subtracted from the RV stroke volume in the absence of other regurgitant region. Finally, we have to keep in mind that the limitation of MRI in tricuspid valve assessment, for example, typically these tricuspid valves are very thin, about 1 millimeter or maybe less than that. And as I said, SSFP tend to perform not to perform well when you have something is less than 2 millimeters in thickness. Also, SSFP sequences tends to minimize spin dephasing and therefore may underestimate TR severity by visual gradient if you just depend on that. Finally, we have some errors in RV volume assessment. It is sometimes difficult, and there is some inter-observer variability as the RV is trabeculated, especially if you and it's when it's inserted in the right atrium, or when the right atrium begin, there is a lot of like some inter-variability bias. Some vendors that trying to use AI and generate to minimize and use quantification by AI to minimize this inter-observer variability, and they have some success with that. Finally, MRI in evaluating bioprosthetic valves, which can be done. Keep in mind the picture is very dependent of the degree of the metal in the frame, which can cause artifacts, and that limits the visualization. So I would recommend doing multiple stack of cine images cuts through the prosthetic valve to get better images, and use GRE and SSFP, most likely GRE. Let me play this. So this is a 68 female with a remote 8 history of aortic and mitral valve replacement due to rheumatic heart disease, who comes with shortness of breath. Echo was done, which showed moderate to severe aortic prosthesis stenosis and moderate to severe mitral prosthesis regurgitation. The quality was very suboptimum, and LV function was poorly visualized. So we did an MRI for evaluation, and as we see here on the cine images on the left, they use GRE instead of SSFP because we can see the aortic valve prosthesis leaflet very well that opens, and that opens very well. And we can also measure the valve area paraplanimetry, as we see here on the right side. The phase contrast flow studies were also consistent with mild stenosis by peak velocities, consistent with the visual impression and measured planimetry. This also, I need to play it. Same goes for mitral valve bioprosthesis. We can see very well on the left SSFP, this one, not even a gradient echo image. In this case, that there is the leaflet seems, one of the leaflets seems flail, and there is a considerable amount of regurgitation due to that, and with a calculated regurgitant fraction of 41%. And we can see also in the in-plane pictures, posteriorly directed MR and the quanta effect with severe regurgitation. Visually, a very nice quanta effect. You can see it in the in-plane. Based on that, the patient underwent a TE, which confirmed the diagnosis, and because of her comorbidity, she wasn't deemed candidate for surgical replacement, and ended getting a very nice transcatheter valve replacement, as we see here. Okay. So in summary, MRI is second line to echocardiogram. Echo, where the echo evaluation is limited and unclear. MRI is a gold standard for right-sided valves. It can give you some accurate quantification of valve disease, and can evaluate associated cardiac defect. And most importantly, which is the growing field of prognostic information, can give you some prognostic value, especially in patients who have asymptomatic moderate to severe valvular disease. Thank you very much. If anybody interested, this is the first ever prescription in the history. This is from Mesopotamia in the Ur period.
Very cool. Mo, thanks so much for that really wonderful overview. Apologies, I signed on a little bit late. Do you mind throwing up the CME slide during the Q&A?
Yeah,
and
sorry.
People can claim their credit. I think this one was ASRT accredited too, right, Shannon? So that any MRI technologists in the audience can claim credit as well. Mo, I thought of something, I never really thought about it until you mentioned the tricuspid valve quantification and how there's decent amount of inter-reader variability because of the more highly trabeculated structure of the right ventricular cavity. Are there any recommendations on, you sort of choose as a lab whether you include the papillary muscles and the trabecular structure into the blood pool of each chamber or the myocardial mass? And as long as you do it as a lab consistently, it's sort of okay. But does that actually make a difference when we're comparing volumetric techniques to phase contrast imaging? Is there any specific recommendations on that?
Very excellent question, Corey. The limitation, as I said, with the RV volume, like you have a lot of trabeculation, you have as you get more to the base, what is the part of the RV, what is the part of the right atrium? That's usually where the errors happen, and that can easily affect your stroke volume. That's a major limitation. There are some vendors and software they can do that automatically with a good accuracy. They have a good AI system that fed with a lot of images, and they have good accuracy for that, and taking multiple images in consideration when they construct that. Also, it depends on your lab. You have to have a standard for your lab. If some labs, they include the papillary, or most labs include papillary muscles, and crista supraventricularis and all of that, and tendons. And if you don't include that, then you have to not include it on the left too, because this also can, may be affecting your measurements. So you have to have a standardized for your lab to work around it. And still with that, you can have some difficulty. And I would say mostly because of the volumetric measures or stroke volume measure of the LV, of the RV.
Great, thanks.
Corey, could I ask a question?
Oh, yeah, of course.
Yeah. Mo, fantastic presentation. I think when we think about regurgitant valvular lesions, we want to know, well, first of all, is it present? You talked a lot about that and the importance of the cine white blood gradient echo imaging relative to the steady state free precession. The second thing we want to know is, what is the mechanism? You had some nice slides there so that we can help identify the mechanism. Third, you want to know the magnitude of the valvular regurgitation, and you walked us through nicely that process. And then fourth, we like to understand the impact of the valvular regurgitation on left ventricular performance. And a lot of that reliably can be measured with the volume assessments and the myocardial mass, and even increasingly now, the extracellular volume fraction. So it's, super for doing all four things, and you can actually follow those along as response to therapy. So the next question, but the question I wanted to ask you, another issue that we often are starting to consider in cardiovascular medicine with the mitral regurgitation pertains to the impact on left atrial volumes and left atrial function. And I wonder, has anyone looked at that issue with this methodology? Because there might be, as the left atrium starts to dilate, there are thoughts about increasing susceptibility to developing atrial fibrillation or what have you, or, just permanent deterioration in left atrial function. It's such a thin wall and it's susceptible to fibrosis. And I wonder, has anyone looked at that assessment as well in terms of its potential impact on overall prognosis, measuring simultaneously with all those four things that we normally do, also considering left atrial volumes?
Excellent question, Dr. Huntley. I know for sure, left atrial volume can be predictor of bad outcomes for many cardiomyopathies. I'm sure valvular heart disease is one of them. Like in ACM, this is one of the things we look at if you have like a balloon or enlarged left atrium. And it used to be one of the guideline features for increased sudden cardiac risk and arrhythmias in the older guidelines. They removed it, but still we look at that and help in guiding treatment and degree of atrial fibrillation. I'm sure like Corey is the guy for the left atrium. But from the echo realm, studies from the echoes, multiple studies in echoes that shows like LA function, strain, kinetics can, and the degree of it's affected by regurgitation or cardiomyopathy can pretend to worse outcome. I'm not very familiar with MRI studies. Maybe Corey can help me out with that. But I'm sure there is if there is not a lot of studies, this should be done to further evaluate it, because in MRI is better than echo in seeing the left atrium. You can really see the pulmonic veins because echo is limited in evaluating left atria from the because it's a deeper structure and you have the pulmonic valve vein shadows and all of that. That also can be the limitation for assessment of LA volume and strain. And MRI can be much better evaluator for that.
Something you might consider, there are a lot of procedural therapies that are emerging to address mitral regurgitation. Certainly we've had mitral valve repair from surgical techniques as opposed to replacement. That really started in earnest about 25 years ago. And now you have mitral clips, you have all kinds of things. And it might be you guys have such a nice process going here, and it's not that much more difficult to extend that series of short axis slices further toward the true base of the heart during several of these exams. And you might want to think about these clinical services and creating a acquisition of the atrial volumes and functions in these mitral regurgitant situations, and just looking at the effect of the medical therapy and the procedural therapy on left atrial function, and whether or not some earlier interventions could be helpful in that regard. Just a thought. You guys certainly have the firepower to do that type of thing.
Excellent input. Excellent. Yes.
Yeah, this is certainly music to my ears. I think it's the left atrium, if nothing else, is probably such a nice barometer of things. And Mo mentioned hypertrophic cardiomyopathy, where you showed a really nice example of SAM causing mitral regurgitation, and that can certainly be a contributor to ballooning at the left atrium. But The other thing we talk about a lot in the echo lab, and it spills over into the MRI lab, is mitral valve prolapse, where there's a sort of late systolic prolapse event. So once it opens up, the regurgitant orifice is severe, but it didn't spend much time of the systolic cycle regurgitating. So the actual regurgitant volume is not going to be that high. So what do you call that then? And I've never really gotten any good guidance on that. We talk about that in the echo lab a lot. And I think sort of the consensus we've come up with is that you can use things like the left atrial size and maybe down the road left atrial function to see what sort of impact is it having on, you know, how poorly tolerated is that regurgitant burden, since it doesn't quite fit nicely into the guidelines otherwise.
Yes, we should look at it, Corey, and maybe we can generate something, a prospective study, and especially for mitral clips.
Oh yeah, that'd be great.
Interventions and prognostic implication.
All right, well, Mo, I know you got to run to get out to Tappahannock, so we might end the session a little bit early today. Thank you again for doing this session. That was really wonderful. And thanks to everybody for attending.
Yep.
Thank
Thanks,
you very much, guys.
Mhm.
Have a nice day.